All right, well then, all the presenters are here, so why don't we go ahead and get started. So we have 50 minutes and 5 presentations. So, we've asked people to talk for about 5 minutes or so, and then that leaves around 5 minutes for questions, so 10 minutes in total. And I will, I'll keep track of time and try to keep everybody on schedule so that we don't short the people at the end. So let's start with, I hope I don't butcher your name, but Bengisu.
Yeah.
Okay, take it away.
Thank you very much. Hello, my name is Bengisu Tulu. I'm a professor of IT at Worcester Polytechnic Institute, and on behalf of my colleagues from WPI and UMass Chan Medical School, I'll present our work on developing a technology solution called ReachCare. This is used to improve care for suicidal patients at the emergency departments. And I'm reporting from an early implementation pilot trial, which is held at UMass. And thank you for being here. All right, so beginning with the disclosure, this was a study supported by an IMH, and we don't have any conflicts of interest to report. I think pretty much all of you know suicide-related presentations at the EDs have been increasing significantly over the past years. And we also know that EDs nationwide are stretched thin with a lot of demand, and behavioral health clinicians are scarce in these settings. As a result, these patients often do not get the support and help they need in the ED. Although there are interventions that are shown to be effective in reducing suicidal behavior in this patient group, we also know that translating these interventions into routine practice in the EDs is challenging because of a number of barriers, such as competing demands, focus on evaluation and disposition, reimbursement challenges, and just to name a few. We believe technology can help support evidence-based care in these settings by decreasing time spent and delivering interventions by reducing the need for additional staffing, while also preserving the quality and fidelity. With this motivation in mind, we developed and tested ReachCare, which is a technology-facilitated version of the ED-safe intervention that have been proven to be effective in the EDs once implemented, but also faced major implementation challenges outside the research settings. Just to give you an overview of the ReachCare intervention we developed and tested, after a patient screened positive on the suicide screener in the ED, we assigned them to one of the 3 study arms where they completed safety planning and behavioral health referral with either a study clinician in person, a study clinician over telehealth, or using our ED app that we developed. All patients were also onboarded to a patient app that they could use after discharge from the ED. And after the ED, patients also received counseling calls from the study clinicians at weeks 2, 6, and 10. They had the option to invite a family member who would receive calls from the clinician also at the weeks 4 and 8. This is just a quick overview of our tablet-based ED app for patient onboarding and safety planning for the self-administered arm. We've published papers about the development of this app and our user-centered approach, so feel free to email me if you're interested in the details of that. This is the mobile app, which provided patients access to the 3 plans associated with ED safe intervention, educational resources, helplines, and local behavioral health providers. And it also allowed them to track their appointments with the study clinician, and they were able to invite their family members and grant them access to the plans completely on their own discretionary through this app as well. And finally, we also developed a portal where the clinicians were able to see the step-by-step guidelines on delivering the different components of the ED safe intervention. As I said, we've recruited our patients from the ED at UMass Chan, and we were screening them for positive suicidal ideation in the past 2 weeks and an attempt in the past 6 months. With that inclusion criteria, we were able to approach 144 patients, and 46 of them completed the study at the end. And these were the measures that we've utilized in order to check how we're doing with our outcomes. In terms of our sample skewed on the younger side, but they were all high users of smartphones, mostly white, given the population that we mostly deal with, but we had a fair representation of the Hispanic population. The three arms were comparable across the three measures: acceptability, appropriateness of the intervention, and quality of safety plans after the baseline completion in the ED. At the same time, self-administered arm took significantly less time. This was the only significant result in this small study. We were not powered to find differences, but at 3-month follow-up, which indicates the end of our study, we found no difference across the three arms related to acceptability and appropriateness of the intervention. And the patient app usability ratings were in good to excellent range, but we noted that trend around telehealth arm receiving slightly lower usability ratings for the patient app compared to in-person and self-administered arms. These were our hypothesized mechanisms of change. We thought the intervention would work to reduce the risk of suicide attempts, and we found ideation, interpersonal needs, suicide-related impulsivity improved over time across the sample. Behavioral action did not improve significantly, but based on these findings, we would likely use these three mechanisms in the fully powered trial. And finally, we conducted chart reviews for everybody to capture the suicide attempts and suicide-related ED visits after the patients were enrolled in the study. Although we didn't have a treatment as usual arm, we believe these numbers are lower than what we expect in a treatment as usual arm. But we need the fully powered trial to test the hypotheses. So with that, I pretty much mentioned everything here, but patients rated our acceptability and appropriateness highly. The quality of and the completeness of the safety plans were comparable. And despite the limitations that I noted, we believe technology may have an acceptable and feasible way to scale up the evidence-based intervention for suicidality. And that's why we're headed for our next step, which is a full implementation effectiveness trial. Thank you very much for listening.
Thank you. We have time for a couple of questions.
For the self-delivered version, I'm Will Lever from Nationwide Children's. For the self-delivered version, was there any clinician involvement, or was it completely throughout the process self-administered?
The ED portion was completely self-administered. We just gave them the tablet, and the tablet app administered the safety plan, and we will held referrals within the short period of time. And then afterwards, everybody got the same counseling calls, which is a real clinician.
I'm curious about the sort of some of the implementation questions, given that the ED is a hectic environment. Can you say something about the challenges or how the implementation went for the three arms?
So the biggest challenge was making sure that the clinician is available for the in-person and telehealth when the patient is available. So the self-administered, as a result, went much more smoothly because we had a research assistant handing over the tablet because we had to onboard them for baseline, because still there was a research presence in the ED. Now, when we're looking into the implementation, actually without any research assistance, I think it's going to come down to, can we make sure that whoever is onboarding them and putting them into a room or a bed in the hallway, because it's kind of unpredictable where these patients are going to end up, will be able to take a tablet and hand it over to the patient. And that's our only current barrier for the self-administered. But whenever a clinician is involved, whenever synchronous communication is involved, we realize how challenging it is, even in a research-supported setting. So we are hopeful that we will be able to make a little bit more progress with the self-administered, fully self-administered arm. And we are, in our fully powered trial, we're considering, does it make sense still to keep the inpatient, kind of in-person or telehealth clinician-dependent version, because we know how big of an implementation barrier it introduces to reducing the care.
Yeah, and so do you have to get, so you hand them a tablet, but then it sounds like you also need to get an app on their phone, or?
So that's onboarded at the end. So the tablet has everything they need at the ED.
Yeah.
And at the end of that process, they basically invite themselves to use an app, and that generates an email to the patient. Most of these patients don't have access to their phones while they're at the ED because everything is taken away, right? So if it was possible for them to just get onboarded on while they're at the ED, that would have been probably ideal, but we will onboard them once they're out through that email. app gives them access to the safety plan that they created. So there's a little bit of a motivation for them. And then the counseling calls that they receive will reinforce that downloading of the app and making sure they have access to their safety plan on their phone. Does that answer your question?
Yeah. All right. Well, thank you. That was a terrific talk. And so let's move to the next. Joe, Wielgosz, or I'm not sure how to.
Yeah, good enough. Yeah.
Good enough.
Thanks. Yeah. So, I'm Joe Wielgosz. I am at the National Center for PTSD, Dissemination Training and Division in Menlo Park, California. And so I'm going to talk a little bit about looking at engagement with the PTSD Coach mobile app in a clinician-supported, so hybrid clinician and digital primary care intervention for veterans with PTSD, and in collaboration with Jason Owen, Kyle Possemato, and Eric Kuhn. Again, the views here are my own, not representing the VA, no conflicts of interest. So I think the topic that I'm looking into is the potential of clinician-supported digital interventions, in the sense that we know that they can be a triple win in a way. They can sustain greater engagement with digital interventions, they can increase efficiency for clinicians, and they can improve outcomes for the recipients of the interventions. What we don't know yet is how best to combine clinician support with digital intervention. And so what I've been looking into is empirical ways we can understand how exactly does clinician support relate to digital engagement. And I'm going to be presenting this from the point of view of using data from a randomized clinical trial of the clinician-supported PTSD Coach intervention. This was a multi-site trial in New York and California. Participants were PA primary care patients with PTSD symptoms. Those in the intervention group received PTSD Coach, which is a free VA mobile app that provides psychoeducation and symptom self-management tools. And they were also offered up to 4 30-minute support sessions to guide and encourage app use that were provided by mental health clinicians over a period of 8 weeks. And the study included 12 and 24-week follow-up as well. Happy to answer any more questions about the trial itself. And here I'll be looking at a subsample of participants for whom we have detailed mobile analytics. So in terms of overall engagement, participants in this subsample came back to the app for a median of 15 visits, which we classify as periods of usage that are separated by under 30 minutes. So this kind of represents a time when, because people's patterns of app use don't necessarily fall into single blocks, this represents a time when use of the app might be clustered and still kind of in working memory. And so the average length of one of these visits was 10.5 minutes. And cumulatively, this added up to about 3 hours of time for the typical participant with the app over the course of the study. That was spread across 13 days, across 8 different weeks of the study. And the typical time from first to last use of the app was over 10 weeks. So we had a substantial length of engagement, substantial dose of engagement with the app during the study. And something, again, confirming what we would expect, we also saw higher levels of sustained engagement. So this is comparing 2 clinical trials that we've run, both in military veterans with PTSD symptoms or diagnosis. The one on the left is a trial of self-guided use of the Mindfulness Coach app to manage PTSD symptoms. And we can see that at week 8, 32% of the participants were still actively using the app. And we know that this is typical, or perhaps better than typical, for self-guided mobile app use, given what we all know probably as the law of attrition for mobile mental health interventions. So on the right-hand side, you can see that in the trial of clinician-supported PTSD Coach app, at week 8, we still had 64% of participants actively using the app. So approximately double the level of retention with digital engagement with the clinician support in place. So then the next question that I've been looking into is, can we understand how app use is temporarily associated with clinician support? So this is a map of every visit to the app by every participant in this subsample. So the colored purple to yellow squares represent the number of daily app visits, with each participant is a row and each day of the study is a column in the plot on the left. And the green circles represent the days of clinician support sessions. So I've been looking at different ways to quantify whether participants are more likely to use the app on times around a clinician support session. So do they basically get a boost in engagement from attending clinician support? So a few ways we could look at this are, we would definitely hope that they use it more on the same day, since typically part of the protocol would be to be going through the app together with their with the clinician who's providing support. We would also hope that they would, we would also think that people may use it in the days before, kind of anticipating the coaching session, maybe completing homework, feeling some positive accountability to the clinician. And they may also use it in the day, more in the days after, which would be representing perhaps a boost in motivation or removal of obstacles to engagement, or following through on recommendations from the coach. And so indeed, looking at comparing days that participants receive clinician support with all other days of the trial, there was a 68% higher likelihood of a participant using the app on the same day as receiving clinician support. We also saw a 13.7% boost in the likelihood of clinician support on the day before the clinician support visit, which is interesting. And also we see as well a boost on the day afterwards. And then one more way that I'm looking into this is looking at day-by-day effects. So besides the days immediately before and after, are there linear or nonlinear trends that day-by-day that's related to when the participants receive a clinician support session? So to do this, I constructed a mixed effects logistic regression model looking at days away from clinician support in either direction as the predictor of interest, and also controlling for the day of the study, since we know that engagement will change over time naturally in the study, trying to predict looking at whether we can predict the likelihood of app usage by day. So we construct a model for each participant and then unify those into a single study level model. And in fact, looking at this model, we see that even after accounting for individual differences and looking at attrition over time, we see for each day closer to clinician support, we see an increase in the likelihood of app use between 2 and 3%. So in summary, for veterans with PTSD using VA mobile apps, we saw approximately a doubling of digital retention and trial post-intervention with clinician support in place compared to self-management. We saw a boost on engagement on days immediately, both before and after receiving clinician support. And also in a linear sense, we saw a boost in engagement day by day with each day closer to the clinician support. So this is an initial foray into really trying to quantify the effects of clinician support on boosting digital engagement, with the hope that with better understanding of this relationship, we can do a better job of integrating the two. So that's everything I have, and I'm happy to answer questions. And also here are more links for more information and finding out about VA mobile apps and our resources. Thanks very much.
Thank you. Any questions?
I'd love to ask a question if I could.
Yeah.
Joe, great presentation. What triggers a clinician appointment? Is that something that is pulled on by the veteran, or is that something that's regularly cadenced?
In this protocol, they were encouraged to schedule sessions at least 7 days apart. I would actually, so as far as the exact timing, I'd have to go back to the study protocol to find out if there were any more considerations involved in that.
And then a follow-up question, are these are all independently licensed clinicians?
These are master's level and PhD level clinicians.
And what is the sort of content of what they're doing in those sessions, or is it sort of anything goes?
It's semi-structured, so it's really focused on participants' needs, and but it's primarily about it's a combination of encouraging app use, navigating obstacles, identifying problems, and kind of guiding them towards features in the app. And then there's some kind of assignment of homework in the sense of kind of encouraging daily practice of a particular tool or trying out a particular tool or reading a particular portion of the app.
Got it. So it is very focused on the app itself and helping
Yes.
the veteran to get the most out of the app that they possibly can.
Yes, exactly. Yeah. So I think, there in terms of this spectrum of different configurations of hybrid interventions, this is centered around the app as the digital intervention, and the clinician support is really designed to facilitate the use of the app. And
that's terrific.
Yeah.
Your 8-week retention rate is outstanding. That's a superb finding.
Thanks.
Congratulations. Yeah.
Yeah, I'm also curious to follow up on those. So yeah, it was a terrific study. I know that there are a lot of data issues in the VA, and I'm wondering, were the clinicians able to see any of the app use data or anything that the participant was doing in the app?
I don't think that we had that in place for the study. So to be clear, I kind of came on after the completion of this study to do the secondary analysis. So I can definitely happy to follow up on some of the fine details of the study. So that's something that we are definitely, we're working on different angles and looking into are ways to provide that during the trial. And in this case, I think they did have self-report from the participants on their app use, but not like a dashboard.
I know getting that data into the VA system, that's a huge, it's not the investigator's problem, it's the VA. So, all right, thank you. Then why don't we move on to our next speaker, Sam Norberg.
See if I can share my slides.
Yeah.
All right. Are those showing up?
Yep.
All right. Excellent. All right. Well, thank you, everyone. See if I can forward them. I do have a conflict to declare. So this work is entirely funded within Optum Care. But I personally have a conflict. I have a financial relationship and I'm a board member of Mental Health Informatics, which owns the computer adaptive patient questionnaire that we use as part of the triage process that I will describe in this. There is no financial relationship in this work between Mental Health Informatics and Optum Care or Reliant, where I am the chief. And I have a strong conflict of interest management in place with Optum Care and with Reliant. Some quick background. You all know this, so I'm going to skip over this real quick. I am the chief of integrated behavioral health at Reliant Medical Group. Reliant has about 300,000 patients in primary care in the greater Worcester area, and serves all specialty needs except for inpatient hospital needs. So oncology, endocrinology, et cetera, as well as primary care. Over the last 4 years, Reliant has built what is now one of the largest integrated behavioral health departments in the state, with 90 licensed clinicians operating side by side with primary care, and full screening of all patients at sick and well visits during the course of the year. And what we've learned by doing this sort of like full bore integration is how hilariously outgunned we are by the amount of need in our patient populations. Even with the resources that we have, PCPs and my department still can't manage the bulk of patient need, and referring out into the community and into insurance company networks just doesn't cut it. This then was the genesis for what we call precision behavioral health. And what this is an effort to develop a continuous quality improvement process by building a practice research network inside Reliant that partners with different vendors of digital tools, vets their technology, and decides whether or not to include them in an ecosystem of different digital tools that cover multiple modalities, ranging from virtual reality, app-based, device-based, FDA approved, somewhat in the wellness space, but all with a strong evidence base and opportunity for us to kick the tires on some demos and feel confident in including them. We get feedback from every vendor on utilization data on a daily basis that goes into a tracker that allows us to surface challenges with folks who might not be engaging in their app as we expect them to. And we currently have 7 apps in the ecosystem and are adding more every couple of months. This system is backed by a clinical decision support tool that lives in our Epic electronic medical record and is used at the time of triage. We triage over 10,000 patients a year when they are referred to us from primary care because the PCP feels out of their depth and unable to clinically manage that patient any longer. Those patients tend to be slightly more complex than a sort of a mild population, but certainly we get plenty of mild and moderate patients, which are really sort of the sweet spot for our focus on digital tools. And then layered on top of that triage process is a digital care navigation process whereby we have unlicensed bachelor's level digital care navigators who onboard patients into the digital treatment that they've agreed to engage with and support them with any technology barriers throughout their journey. We also have our integrated clinicians who, if it looks like the patient is going off track or has stopped engaging with the tool, will reach out and re-engage that patient, find out if they want to be triaged into something else, if something has come up, generally check in about what they need. We also do a routine 6-week follow-up with a clinician for every patient who's assigned into a digital treatment. I'm not going to go into the specific digital treatments, but I am going to cover some of our early findings. We referred about 1,000 patients into digital treatments who have agreed to our treatment offering. And what we see right off the bat is that we are able to get patients connected with care more or less immediately. The moment that we identify their challenges, we are able to triage them either the same day or next day, and we're able to get them started with an intervention immediately. So we have reduced the median days to a visit from 24 to 1. In many cases, this is a same-day intervention for that patient. We've improved retention as well, although not as well as Joe's study from the VA. But if we look at the industry median for app-based care as delivered as part of EAP, for example, or recommended by a PCP, what we see is that we're doing an awful lot better at 15 and 30 days than those benchmarks are. And we continue to learn more and more about keeping our patients engaged with those technologies. We're just finished the first year of this engagement. And then we also see significant reduced symptom rates. We track symptoms over time, and we look at treatment effect sizes, and we see that our results look to be roughly comparable with psychotherapy, although we don't have enough data to confidently say that we can compare. And we're being very careful about selecting which patients we pair with digital treatments. So I would not say that this is an apples to apples comparison with psychotherapy, because we are being very thoughtful about who we pick for a digital treatment versus psychotherapy. Lastly, this is just a quick preview. These aren't statistically significant yet, but they're beginning to trend in a very interesting direction. These are all of the different scales that we measure patients on using our computer adaptive measure. And as we are now getting dozens, for some apps, hundreds of completers through our measurement-based care model, we are able to look at who did well and who did poorly. And here what we see are, these are the baseline scores, the baseline average scores of people who either did well in an app, meaning they're in the green, represented by the green bar, or they did worse in the app over time, meaning they are in the orange bar. And what we see here are a couple of indications for one of our apps that say to us that even though this app actually is designated for major depressive disorder, when someone's general functioning and sadness are high, they appear to do worse in this app than they might in another treatment. This kind of data is what we will be using to reinvest in that model of care and in that clinical decision support system, so that we are improving it over time and making better and better data-informed referrals as we move this work along. So, a couple of key conclusions. We absolutely need models like this if we are to give every patient who needs one an intervention. having just one app is not going to cut it. We need an ecosystem of different tools that appeal to different people in different problem areas. And therefore, precision measurement and precision matching are going to be key research initiatives over the next decade. And lastly, consistent with the work that Joe presented, we find that a human connection is incredibly important to increase the likelihood of getting patients engaged and keeping them engaged. And with that, I will stop and see if we have some time for questions.
Thank you so much. This was great. Any questions?
Was your digital tool suite developed in-house, or were you taking ones already developed?
No, entirely developed in-house. I will admit that we reviewed over 700 tools, and we have an in-house research team that kicks the tires on published and unpublished research. And then we have an in-house clinical team that gets a demo of products that pass our research benchmarks. And we demo those products with about a dozen clinicians before we decide whether or not to include them in our ecosystem. So it's a pretty rigorous process.
What are the so for the 7 apps that are currently in there, what can you say a little bit about what they target and how you make decisions about where to send people within those?
Yeah, we're really trying to target mechanisms of change, principally for anxiety and depressive disorders right now. So the bulk of our apps are targeting things like really excellent diaphragmatic breathing training, or really strong mindfulness training, either through virtual reality or through an app with a lot of social connectivity. Again, trying to have multiple modalities, attention shifting, either with some gamified technology that keeps your attention on the attention shifting task, or with virtual reality. And we also have some device-based technologies that help you with diaphragmatic breathing, for example. So as we continue to build out more robustly, we are onboarding some apps that a virtual reality app for pain management, and beginning to build in some apps with sleep, like CBT for insomnia. We don't see that sort of a huge diversity in what the technologies are going after. What we see is a diversity in the methods by which they're going after the same techniques. And so we're trying to diversify those methods to appeal to as many different patients as possible.
All right. Well, thank you so much, Sam. I wish we had more time to talk, but let's move on to Karen.
Yeah. Okay, let me share this.
Okay, looks good.
All right. So hi, everyone. I'm Karen. I'm a research manager in the section for community behavioral health in the psychiatry department here at Rush University Medical Center. Today, I'll be sharing with you about a digital mental health tool that we developed and implemented in the context of COVID to our West and South Side communities in Chicago, and what we're currently doing to try to make it better based on stakeholder input. Okay, so first I'd like to thank this lovely team who were all at Rush at one point or still are. And I'd also like to acknowledge the funding that made the development and implementation of the digital mental health tool possible. And of course, there are no conflicts of interest. Okay, so in 2020, COVID hit Chicago. But before jumping into the impact of COVID on our communities, I'd like to briefly take a look at the status, the health status of Chicago pre-COVID. So we know that pockets of the city have long been afflicted by the effects of systemic barriers. Here we see a 2015 map that shows the differences in life expectancies off of the CTA train lines, and the areas with the lower life expectancies are primarily made up of Hispanic, Latino, and African American Black communities. So by the time that COVID came around, many of these communities were already facing significant challenges in accessing social and healthcare resources, and the pandemic only exacerbated those barriers. So in this maps, we see self-reported physical health and mental health, and we note that it maps on pretty well with the figure we saw in the previous screen. Okay, so 2021, enter the energy system. So this is our digital mental health tool. We know that digital mental health tools can be a good way to access evidence-based interventions and resources. So with this in mind, we developed the energy system to assess resource and mental health needs and provide automated, personalized resources based on those needs. So here is just some snapshots of our marketing material that we disseminated widely across various platforms and media. And then we sat back and watched all of the clicks roll in, right? No, not quite, actually. The uptake of the energy system was low, and it's also likely that we didn't reach the intended populations that we wanted to reach, so those needing the most support. Oh, sorry about that. So how do we reach those requiring additional support? So we asked our community stakeholders. We invited members of Chicago's communities to participate in sessions that focused on the usability of the energy system, as well as other factors that might impact its reach and its uptake. 23 participants enrolled. So that's 7 minors, 10 adults, and 6 community engaged clinicians and support staff. And the majority lived in within the Chicago city limits. So here are demographics for our minors and our adults. For the minors, a mean age of 15.86, mostly cisgender female, mostly Black or African American. And then for the adults, 34.3 mean age with a nice range, 21 to 71. And then across both groups, most were heterosexual, straight in terms of sexual orientation, and a good representation of minoritized populations in both groups. Okay, so very broadly, we did come up with some themes emerged. One of the most prominent and first to emerge was design and added features. So this makes sense. We implemented energy in RedCap, and RedCap is like a research data collection platform that doesn't have a bunch of cool features. So it was only natural that folks bring these topics up, right? Colors, design, visuals, flavor, as one team called it. So folks also suggested that we might create an app or a website that includes a login as an added feature, and that we might consider providing this tool in other languages. So that also makes sense considering our populations here on the west side. So another thing that emerged is marketing. So social media and word of mouth were brought up frequently in terms of how to get the word out and disseminate this tool. But with the caveat that this is worth the click, as somebody mentioned. So it has to be exciting. It has to create buzz for people to spread it via word of mouth. Something else that came up that was really interesting was a presence in community settings and networks and partnerships. So keeping in mind how we disseminated the tool, we did disseminate the flyer wide and broadly, but we didn't really establish those partnerships, right? We weren't present in community as much as we could have been. We weren't present in our community-based organizations or in constant contact with them. So that really stood out. And shout out to our budding researcher towards the bottom who wants to see studies that this tool actually works before she engages with the tool. So, in terms of screening questions and types of resources, participants brought up potentially adding questions, particularly around relationships. So not just like intimate or partner relationships, but relationships with friends or family, as well as adding resources for human connection and in-person activities. That was big for the teens, for the kiddos. And then a few other suggestions here. For privacy and security, most people felt comfortable filling out the questionnaire, probably due to its anonymity. People did state that. People did suggest that if somebody wanted an added layer of security or protection, we could roll out like a login or a passcode feature or something like that. But for the most part, it was pretty well received with no real concerns about security or privacy. So our clinician and support staff community members were such a fountain of information. They had so many ideas for implementing this tool within their existing workflows and their clinics, how to implement it, who to give it to, and how to add it on to their existing services. So they were just so helpful. They also pointed out two really important points at the bottom. They really emphasized that we should make sure that our resources actually work and that they're accessible, because a lot of the time, we send patients or clients home with these resources and they lead nowhere. And then they also said that we should keep in mind our extremely underserved population. So expect that people have undocumented status, expect that people have no insurance, expect that people have no housing, et cetera, and then build it that way. So we're really excited about these these clinicians and support staff, and we're hoping to bring them onto a community advisory committee to continue the conversation. Okay, so our next step is going to be a little bit of a glow up. So we are currently working with software for research. Shout out to Jeff, who's in this room, I think still, aka Purple Workshops. We are going to try to make the tool better, more appealing, and kind of address some of those points in the first theme that we saw, because we really want this tool to get out there to our Westside communities this time and for them to be used and be useful. So that's coming soon. Okay, that's it. Thank you.
All right. Thank you, Karen. That was terrific. We are running a little late, so I'm going to ask if people can just put questions for Karen into the chat if you have them, and maybe you can answer them that way. And now we'll move to Lauren.
Yes, let me just share.
I promised I would leave time for, so.
Awesome. Can you see only the right window?
Yep.
Okay, one moment. Yes.
Now it's not looking good.
Let me reshare. Sorry about this. We use Teams, and that has gotten me out of the practice of Zoom sharing. Sorry about this.
Looks good.
Okay, one moment. Great. So my name is Lauren Weiner. I'm the Director of Clinical Science at Kasana Health, and the project I'm talking about today is an academic industry collaboration between Kasana and Columbia. The study was funded by an SBIR from NIMH to Kasana, and myself and the other Kasana co-authors hold stock and receive salary from the company. The other co-authors have no conflicts to disclose. Today, I'm going to be talking about Vera, a digital behavior change platform consisting of a client app and a practitioner dashboard that offers insights into a client's mood and behavior. Using passively collected smartphone data, Vera provides valuable information about clients' daily activities that can help practitioners tailor treatment plans and support clients in achieving their mental health goals. I won't have enough time to talk about all of the different features of Vera, so if you're interested, there's a QR code here, and the QR code will reappear on subsequent slides. The Vera tool allows practitioners to connect with clients between appointments and send timely support and communication using real-time data to guide their interactions. For example, practitioners can send reminders to practice specific therapeutic techniques or schedule validated questionnaires for their client to complete within the Vera app. The reminders show up in the client's app, and when they mark an activity as done, the practitioner can see that on their dashboard, thereby facilitating real-time information about client engagement and adherence to treatment plans. The purpose of the study I'm presenting on today was to conduct an iterative formative development process to enhance product fit and plan for successful implementation within a pragmatic RCT in an intensive outpatient treatment service for youth at high risk of suicide. And I have to admit, that's a very academic sentence, and I don't say a lot of those now in my industry job. But we're really excited about the approach that we used. We used mixed methods informed by a user-centered design process, which included 2 iterative phases. Phase 1A was formative in nature, focused on developing and refining the prototype and understanding barriers and facilitators to implementing the tool in practice. Phase 1B was a usability test focused on refining the prototype and planning for implementation. A subset of clinicians from the 1A phase completed an unmoderated mock case study where they were provided with client data, a case scenario, and a corresponding data in Vera Pro, and they clicked through a prototype while thinking aloud about how they would actually use the tool in practice. The results I'm presenting here are a synthesis from 1A and 1B. To begin, practitioners described immense administrative burden and sought tools to reduce that burden. They also were excited about using continuous behavioral methods of Vera to identify risk factors for their patients and Vera's just-in-time adaptive intervention capabilities, as well as features that would allow them to connect and collaborate with other clinicians. They felt Vera would be easy to learn and use, but they had varying perceptions about the extent to which it would actually help them be more productive and efficient. They also noted they didn't have much time to learn new tools. Most practitioners and administrators were very interested in EHR integration, and some important considerations they mentioned were having single sign-on, not having to upload any paper documents. They were very excited about having the validated questionnaires integrated into the EHR in particular. Administrators, more so than practitioners, noted potential challenges around integration, contradicting protocols, general friction, clunkiness, nothing that should be surprising to anybody who is working with an EHR. So these insights directly informed the development of a very focused training approach for practitioners to get started with using Vera. In response to their feedback about having limited time to learn new tools, the blended synchronous and asynchronous format provides flexibility while also keeping the training very focused and efficient, rather than an additional to-do in an already long list of after-hours tasks. To address mixed views regarding whether Vera would help them become more productive and efficient, the training emphasizes critical thinking and how to apply the Vera platform into their practice. The training sequence focuses on building their self-efficacy for using the platform, especially through the guided practice, as well as getting feedback from a licensed clinical psychologist about how to actually use the data in session. We're really hoping that they'll see the platform as something that can enhance their practice and help augment their ability to do existing tasks. And there are also many resources available for asynchronous review and support after the training. I'm not going to go through this in depth, but we'll be evaluating and refining our approach throughout the trial by collecting feedback from clinicians, practitioners, administrators, leveraging objective app and platform-based metrics when available. This is just a snapshot of the practitioner evaluation plan. We'll be collecting data at different time points. And so overall, this user-centered design approach supported simultaneous product optimization and implementation planning. And our implementation plan really focuses on supporting practitioners in successfully using the tool to enhance their practice. Today, I shared results that informed the development of a focused training approach. We, as is common with mixed methods data collection, we gained a lot of data that will help us understand how to support practitioners throughout the trial and in actual implementation of the tool. And our continuous evaluation approach will help us iterate and adapt. Kasana is pursuing many different implementations, even beyond this pragmatic trial, and we're just really excited to be able to triangulate all the feedback across contexts so that we can refine this tool and its implementation. Thank you. And thank you for saving time, David.
Yes, and thank you. It's nice to see some user-centered design with clinicians and not just patients. So any questions? I guess, maybe just sort of broadly, one I have is getting clinicians to use anything is probably more challenging than getting patients to use something. And I'm wondering where you see the sort of the biggest barriers or challenges going forward. And this is integrating it into standard psychotherapy or behavioral medicine.
Yes.
Yeah.
Yes. So the pragmatic RCT is integrating it into a DBT clinic, that intensive outpatient program for youth at high risk of suicide at Columbia. And so honestly, even scheduling these trainings was a major to do. And so I think overall, finding ways for this to just become a way that they're enhancing their practice and not having it become so easy. I think yesterday there was a lot of talk about ease of use. And so having it become an actual easy, not clunky tool, something that integrates pretty well, should hopefully increase adoption and use. The technical aspects, I mean, I could talk from being we're a small 15-person startup. So resourcing for troubleshooting bugs. And I think we need to prioritize bugs that are impacting practitioner use, because if practitioners are not using the tool, they're not going to use it with their clients. So when there's client-facing issues, they can feel like a big deal, but the practitioner-facing issues would be really important for us to troubleshoot and try to make it as easy to use as possible.
Interesting. We're just about at the at time, so if people want to jump off, that's fine. But if there are any more questions, I'm happy to stay on for a couple of minutes. All right. Well, then I think that's a wrap. So thank you to all of our presenters. This was a great session, and we will see you back in 10 minutes or so.
Thank you.
All right.
Thank you.
Bye-bye.
Thanks, everyone.